Hello and welcome to Trust Your Gut, Navigating Bowel Endometriosis, which is part of our ongoing endometriosis series. Please ask your questions through our chat function. While we will try and answer all your questions, we may not get the time to answer them all. You can email us any additional questions via the email on screen. You can also find out more about the Menstrual Health Project via the URL shared on screen. This webinar is being recorded and you will be sent the recording tomorrow. The International Centre for Endometriosis at Cromwell Hospital is a leading centre for the diagnosis and management of endometriosis. And I would like to now introduce to you Mr. Amar Raza, consultant gynecologist and expert in complex endometriosis. Mr. Raza, over to you.
Thank you very much, Hattie, and thank you for all of you who are joining us and who have already joined us as well. It's a pleasure to have all of you here. And I'm so happy and excited today to have a great experts with me in this panel to talk about bowel endometriosis. Bowel endometriosis is absolutely hugely concerning issue. But before I go to bowel endometriosis, just briefly to say I'm Amir Raza, consultant gynecologist and robotic surgeon for endometriosis in Cromwell Hospital. I lead on to one of the largest centers in endometriosis surgery in UK and Europe now. And I have my colleagues with me and I will just move them along. They can introduce themselves. I will start with Mr. Ahmed Karim, colorectal surgeon.
Hi, good evening, everyone. Thank you for joining. Thank you for the introduction, Harriet and Amr. I'm Ahmed Karim, colorectal surgical consultant specializing robotic colorectal cancer and, of course, endometriosis. And hopefully we'll give you a flavor and a guide about the need and requirement for intervention and management as and when required. Thanks, Amr.
Thank you very much. Kanish.
Hello, I'm Kinesh Patel, a consultant gastroenterologist at the Cromwell Hospital, and I'm a medical doctor and have this particular interest in the management of symptoms related, GI symptoms related to endometriosis and other medical conditions affecting the gut.
Thank you very much. And we are to Elizabeth.
Good evening, everyone. My name is Elizabeth McCann. I'm one of the specialist dietitians working at the Cromwell Hospital. My area of specialist interest is gastroenterology, and I have the fortunate opportunity to be able to work with individuals with endometriosis, both during their inpatient stay and with the nutritional long-term management of their endometriosis in the outpatient setting as well here.
Thank you very much, Elizabeth. Great to have you here. And last but not least is our Anna with us. Anna is the founder of Menstrual Health Project charity. If you talk about any journey of anyone from pain to power, it will be Anna, going through so much challenges, but still smiling and with us, telling us, educating all of us about endometriosis, its challenges, and how we deal with it. Anna, please go ahead and introduce yourself.
Hi, thank you so much for having me. I'm one of the co-founders of Menstrual Health Project, but I'm also patient voice on the webinar. I've suffered with bowel endometriosis since the age of 18, officially diagnosed, and I live with an ileostomy as a result. But I'm so looking forward to the webinar and I think it will help so many people. So thank you for having us.
Thank you very much. Okay, so we're going to start now. The way we're going to do it now, I will do a very short presentation for literally 5 to 7 minutes to talk about endometriosis and bowel endometriosis. I will then pass the baton to Ahmed to talk about the colorectal surgeon. He's an amazing colorectal surgeon, a robotic surgeon who comes and helps with us with complex bowel endometriosis cases, from simple shapes all the way to very complex diseases. And then I will pass on to Kanish Patel. Now, Kanish is absolutely a very pivotal role that no matter how good surgery we do and how radical we are to excise and remove the disease, but there could be functional bowel issues and other issues on the back of it that still we may have symptoms. And that's where Kanish comes in and helps us with this very complex bowel issues as well. And obviously we'll move on to Elizabeth. And then Anna will tell us about her own story, that how it is. I think, Anna, should we start with you? Actually, you have lived through it. You are the living experience, which we're going to talk in the next 1 hour. Tell us about your experience and how you have lived through it, and then we'll take it from there.
Yeah, it's been up and down, as you know, but I probably started with kind of severe bowel symptoms when I was about 13, 14 years old, to the point it wasn't just heavy painful periods from the age of 11, but it then became, I was getting rectal bleeding, but cyclically. I couldn't eat certain food groups. It would always really irritate my bowels, to the point it was kind of, you know, clutching to the toilet because I was having such bad diarrhea. And then it would go polar opposite to then constipation, where I just couldn't go, and often I was just batted back as that it was IBS and that I would just, you know, needed to manage what I was eating. And it wasn't until I had my appendix removed as an emergency when I was 17 that the general surgeon at the time said, it's not your appendix, you've got endometriosis everywhere, especially involving your bowel. And that's when really I'd heard the word endometriosis for the first time, didn't put two and two together with my bowel symptoms and my periods, definitely didn't think they were interlinked. And it's only through obviously suffering with it myself, and then obviously working with loads of medical professionals like yourself, that you realise that actually how involved your bowel can be with endometriosis, and how you know, you should really track your bowel symptoms and your bladder symptoms, because I've obviously got a urostomy as well as a result of endometriosis, when it comes to your endometriosis symptoms. And when I was 17, I went to a private consultant because my general gynecologist wasn't helpful. And my consultant said, let's go in, let's excise what's there. I don't think there'll be a huge amount, otherwise your first gynecologist would have seen it. And the general surgeon said that you had it, but didn't really go into how extensive it was. Went into that surgery really kind of blindly, to be honest, didn't expect very much, thought, oh, I'll be absolutely fine, I'll have the surgery and I'll be all good. And the reality was very much different, and I had to come out and then had to go back into major surgery 2 weeks later, where I had my large bowel excised and also my rectum excised because of the endometriosis. I also had my bladder excised as well. And at that point, I had a resection and managed to narrowly avoid a stoma at that point, which I was incredibly grateful for. And then from probably my early 20s, after I had my daughter, things really spiraled out of control, to the point I lost complete bowel function. So I would go, you know, I would take my daughter out for the day and I'd just be incontinent. I just had no control whatsoever over my bowel symptoms. And they put a sacral nerve stimulator in to try and control that. It controlled it maybe for about 6 months, and things kind of went from bad to worse, to the point I then ended up not being able to eat. I was hospitalized every 3 weeks because my large bowel was so backed up, and it was because the endometriosis, what they said, was strangulating a part of my large bowel, that it just couldn't pass the waste that needed to be passed through. And that's when I ended up having an ileostomy, and that was March 2020. But at the time, again, they did a loop ileostomy and kind of just resected the part of the bowel that was damaged, and thought that that would be enough. And actually it didn't. My loop failed and shrunk under the skin, and my skin grew over the top, bypassed the loop, and ended up nearly at perforation. So I had to then go back into emergency surgery to have the entirety of my large bowel removed. And now I live with quite a short small bowel because how much they've had to resect of that, and also a rectal stump. But we're trying as hard as we possibly can to leave my rectal stump in place, because as we know, that's a big surgery. But I do suffer terribly with rectovaginal endometriosis, even post hysterectomy. So it's been a difficult journey. And I think the biggest thing I've come up against is the lack of knowledge when it comes to endometriosis, especially impacting the kind of outside of the pelvis. And, you know, I've had consultants say to me, endometriosis can't impact the bowel, like it'll just be IBS. And that's when I've sat there with a stoma bag as a result to it. And I think it comes down to a lack of education, a lack of knowledge, and why things like this are so important, to really educate people like myself, because I really wish I'd have kind of fought my corner a lot more when I was younger, because maybe we wouldn't end up with permanent stomas as a result. But you know, I have to say, having an ileostomy gave me my life back, and a sense of kind of gaining control back, because the damage was far too gone. But I do think I wasn't educated enough, and I didn't know enough about how endometriosis could impact your bowel, and why it's important, I think, to get to the right specialist early and to be able to navigate that properly. And I think things like this will help patients massively.
Thank you very much, Anna. You just put the whole thing into a very painful story, into something for all of us, something which lives in the dark. You brought it into a light. So thank you very much. And I think next 45 minutes to 50 minutes will be really shedding lights on this challenging problem, which you very nicely described to us. So I'm going to start now. I'll share my screen with all of you. And just give me a second. It will just I hope you can see my screen. Can you? I think you can see my screen now. So can everybody see my screen? I suppose yes. So we are talking about endometriosis and endometriosis in the bowel. This is, we are all sitting here together as a team from Cromwell Hospital. It's an international center for endometriosis. We are now the largest endometriosis center in the UK by doing 161 complex cases last year, more than any other unit in the country. It's not one person job, it's a very large team. We have colorectal surgeons, thoracics, urology surgeons, physio, dietitian, psychotherapy, chronic pain team, thoracic teams. We're just sitting very functional gastroenterologists. We are just very few people sitting here, but team is very large. And all the team, we pride, they're all robotic team at the cutting edge technology of treating endometriosis as well. The endometriosis challenge, which many of you know, and it's a multi-system, multi-organ disease. It's not one system involved. And obviously, we're talking about bowel here, but it can involve bladder, it can involve the abdominal wall muscles, it can involve the diaphragm. I can keep on going with how many structures it can involve. This disease grows like a cancer. It develops its own angiogenesis, it develops its own nerves, but obviously it's not a cancer, it's a benign disease. But the way it grows and penetrates into the tissue, it looks like very severe disease as well. It leads to tissue trauma, inflammation, scarring, adhesions, and when things start to stick back together. But as you know, many of you will know, and as we learn more and more about it, that we still do not know what starts it, what happens, what makes it worse. And what I put it actually is an etiological confusion. We do not know where it starts, and therapeutic anarchy, because simply we do not know where to start the treatment, and from medicine to surgery to other occupational therapies. So it's really a big challenge for us. And this picture just depicts that challenge which people have for years, and sadly we're still sitting here today and not very further away. This woman has been suffering with severe pelvic pain, having an operation in a French hospital, but this hospital is not a general hospital. It's a psychiatric hospital where she's having a hysterectomy. So they think she's mentally crazy because she screams with pain every time, every month. So this operation of hysterectomy and oophorectomy is being carried out in a French hospital, in a psychiatric hospital. That has been the lack of knowledge, and that lack of knowledge, whatever the reasons are, political, otherwise, it still goes on in our world. The principle of endometriosis surgery is very simple, and we will talk about bowel here. Number one, it has to be organ protective. Whatever organ we are treating, the bowel, the bladder, the thoracic, whichever organ, we have to be, and ovaries, we have to be careful, and because it's a benign disease, we have to protect the functionality of that organ. Two, neuroprotective, very important. All these organs are supplied by the nerves. Either we are treating them medically or surgically. We have to make sure we do not cause any nerve damage to these structures as well. Obviously, things have moved on to robotic surgery, which gives us a huge precision, and this as well. And now from there, actually, we moved on one level up, actually, where we have moved to single port robotic surgery. So you have a small hole, 2 centimeters in the belly button. And when it comes to bowel endometriosis and this endometriosis, we go on to excise all the disease from this very miniature instruments to do it. Yes, it is not available in every hospital, but I believe that we should be absolutely breaking the boundaries to to have the best care for women, and especially disease like endometriosis. When it comes to endometriosis care, it has to be done in a certain setting. So wherever you are, whichever part of the country you are, when you go for endometriosis, and especially you have a bowel endometriosis, you should ask for, does this hospital, does this unit, private NHS, has MDT, a multidisciplinary approach toward this disease? Number one, every person treatment is different from the other one. So everyone has to have a bespoke treatment for yourself. Your treatment may not apply to somebody else. Thirdly, everyone has to be BSGE accredited center. BSGE tells very clearly who should be operating on these cases. So when you are going for a treatment or an operation, you should know that this is an accredited center or not. And this is not a one-off operation, a one-off treatment which will cure the problem. It is an ongoing issue for which you need to have a team to support you through that one. And for a simple fact, the patients who are coming to us, they're young. It's a benign disease. Fertility is a very big issue. And surgery itself is a very risky surgery. No surgery goes without a complication. And this is so important, this risky surgery, to be carried out in a multidisciplinary setting, so to reduce the risk to our patients as well. When it comes to bowel endometriosis, it's a big challenge for us. And simply because symptoms of bowel endometriosis vary from so much that it's very easy to miss it, from constipation, bloating, spasmodic pain, sometimes with periods cyclical. So picking up this one person who has endometriosis among the crowd of so many symptoms is a challenging thing. But that thing needs expertise and the right place to be seen by the right people. I will just share two images with you, which will just leave you with them before finishing my presentation and moving to Ahmed Karim, who will talk about the treatment. This is absolutely the normal pelvis I'm showing you. We have a uterus right on top of the screen. We have a right fallopian tube, right ovary. We have a left ovary, and you can see the ovulation is happening on the left ovary and left fallopian tube. Beneath, you see the bowel at the bottom of the screen. We call them uterosacral ligament. This is the arch of the uterosacral ligament. It is actually the area behind the vagina, behind the cervix, and rectum or back passage is somewhere down here where you see my camera. So when you look at this pelvis now, it looks clean. There is no adhesions, no scarring. Now let's see what we mean by bowel endometriosis. Bowel endometriosis, that's what it is. Complete distortion of the anatomy. We can see the bowel is all stuck on the back of the uterus, both ovaries on both sides, a kissing configuration, stuck with each other. This is a completely obliterated pouch of Douglas, and there is no anatomy. And this actually bowel is adhered here all the way to back passage. There's about 9 centimeters of bowel attached to the back of the uterus. How this bowel will function normally. And no wonder that symptoms like bloating, abdominal pain, bleeding per rectum, all these things will become a common phenomenon. This is a really severe disease, and this is another severe disease when there's absolutely, we have lost the anatomy, the identification of structure. The fallopian tube is all curling around back of the uterus, ovaries with endometrioma tethering. So losing this whole anatomy in this severe disease brings up that challenge that not only is the bowel, but all the structures around it are affected as well. And that's what we call bowel endometriosis, and a challenge doctors need to meet. There are many ways to treat it. I won't go into detail, but just will want to leave you with 3 words here, which you will hear from your surgeon when you go there. Number 1, if the disease is attached to serosa only, there is a shave. We can shave the disease off and remove the disease. However, if disease is going deeper, involving the muscularis, but a relatively smaller area, disc excision, between a small hole in the bowel, and will remove the disease. And third stage is that the whole lumen of the bowel is involved, much larger area is involved, then we will need to do bowel resection and anastomosis. This is the part of the dynamic multidisciplinary team where we work with colorectal surgeon, our urology colleague work together to make the right decision, not only in the MDT before the surgery to say we are doing the right decision between either of those 3 procedures if we proceed to surgery, but even during operation. It's a continuous discussion between the gynecology surgeon and the colorectal, what should be our right approach for this patient as well. So I will leave you with these 3 words, and obviously we'll come back to your questions. And I think I'll give the baton to Ahmed now, who is a colorectal surgeon who comes to help us. Ahmed, please.
Thank you, Amr. And thank you for sharing your story as well.
You can share your screen now.
Okay. Okay, with me now. That should be there, and we can start the slideshow.
Presentation mode.
Yeah. Is that, you can see all that?
Yep, thank you.
Excellent. Okay, thank you very much. Thank you, Amr. So, as you said, my name is Ahmed Karim, colorectal robotic consultant working at the Cromwell Hospital, working very closely as part of a team. And what we want to do is just touch upon some of the subjects Amr has mentioned and how actually the journey of our friend will be apparent in what we're describing today. And we'll also discuss a little bit about the access methods and the movement and advances in surgical techniques that are really bringing options to our patients. You know, with the epidemiology of endometriosis is quoted as about 10% of women. And really, what's very important and what we've seen perhaps over the last 5 years is people gaining more information and understanding about endometriosis, and that's raising the awareness. As a result, from that population, we're now seeing and identifying the bowel involvement of endometriosis. And that can cause these multi-factorial symptoms. And people for years, exactly as was described earlier, are told they have other symptoms. And, you know, Dr. Patel, who's our gastroenterology colleague, will talk to you about patients that come to him. And, you know, he's key in identifying those who had endometriosis and those who have had endometriosis surgery and then have that functional symptoms after. And that's what we really want to raise awareness about. It's the pain symptoms, it's digestive issues, and it's the signs that we want you to highlight to yourselves and friends and other people that will cause them to seek healthcare advice, to have appropriate assessment. You know, for many, many years, it's the patients that were being managed as IBS and, you know, I'm a little bit sensitive to this food and so on, which many patients will indeed be. But that needs to be a diagnosis of exclusion. So we need to rule out other causes. Real key signs, we call them the critical signs, are bloody stools, painful intercourse, and the cyclical symptoms. So if you're having GI disturbance that is happening in accordance and in pattern with your menstrual cycle, that's really a telltale sign that you may be suffering from endometriosis. Really, when we're talking about the surgical options, when we perform the endometriosis surgery, it's a multi-specialty approach. You know, Amr as a lead gynecologist for endometriosis at the Cromwell, and myself, and we have a urology team, the thoracics team, all involved for certain selective cases. We make sure we do a full assessment. You can see on the bottom right, that's the current technology we use is robotics, and I'll talk a little bit about that. We do a complete assessment. So while we have up-to-date imaging in the forms of scans, ultrasounds, and MRIs, intraoperatively, we will be doing a complete assessment and we'll discuss your case and make sure that appropriate access is selected. Now, this is a very helpful image. Sorry if it's a little bit detailed, but we're going to be looking at those 3 lines. And these are the 3 words that Amr mentioned: shave, disc, and segmental. Okay, and I'll talk you through each of those. If you're looking at the purple line, the green line, and the blue line there. If you imagine this is a cross section of your bowel, cut like a salami slice. And on the right, you see the muscle layers, the mucosa, and the serosa. The first technique I'll talk about is the shave, and you can see that's the purple line, and that's where the bowel is just touching the serosa. The endometriosis is just touching the serosa of the bowel, pardon me, and it means we're able to shave that off and just lift it off, preserving the integrity and not entering the bowel lumen. This, of the options, is the lowest risk profile. We now look at the discoid excision. If you look at the green line on the left of the screen, that is when you have a nodule. Currently, we quote under 3 centimeters that involves all the layers of the bowel wall. It means we're allowed to take a full thickness of the bowel wall, almost like a coin, whether it be a 50p piece or whatever size it may be, and we'll reconstruct the wall of that bowel. Previously, it would be with sutures, but now we use a combination of stapling techniques as well as suturing, and it allows us to do a precise repair. And its function on your bowel thereafter is therefore described as minimal. These are a little representation of what indicators to do the discoid excision would be. Segmental bowel resection is for those lesions that involve a segment of endometriosis larger than 3 centimeters or multifocal disease. These tend to be larger nodules. Patients tend to be more symptomatic. We'll take a segment of that bowel just either side of the endometriosis and we'll preserve all the normal tissue. Patients that come and see us are always very anxious about the word segmental bowel resection, but the way the techniques have evolved, longer term, the consequences or the impact on your bowel function is really minimized compared to some of the unfortunate journeys we've seen in the past. We've talked about the surgical access. We currently at the Cromwell, there's the utilization of the multi-port system, which is the XI. That's currently where the surgeon would be sitting at the console, and then the small arms, each the size of a fingertip, articulating in 7 degrees. That gives us 3D vision and real precision. Amr has already shown this video, and Amr is currently the lead for endometriosis on single port access in the UK, and Cromwell is one of the only units in the UK doing this. For post-operative care and complications, we know with the minimal access approach, and of course engaging with you in your pre-operative workup and in your post-operative recovery, the hospital stay is somewhere between 1 and 3 days, depending on what's done. The recovery timeline, depending on your work, would be somewhere between 2 to 4 weeks to get back to your normal energy levels. And the potential complications, we talk about things like anastomotic leakage, bleeding, and infection. A lot of patients will have unfortunate stories where they've been quoted high numbers for anastomotic leakage. In our practice, the anastomotic leak rate, as by our numbers and cases, is less than 2%. So we can be reassured. And I think all my colleagues will echo the commonest question we get asked in any clinic is the word stoma formation. Stomas are very rarely used. And now with appropriate access and planning, our stoma rate is less than 1%. And in these cases, usually are reversed within 3 months where viable. So the important thing is appropriate assessment, selecting the right technique, and it's a multidisciplinary team approach. While the robotic access improves the precision and visualization for technically demanding procedures where they used to be very challenging. It's important for early identification, multi-specialty collaboration. As Amr and the team who said, make sure you're at a unit that has multiple people from all the different specialties. That is where you're going to find the strongest outcomes. So the key is here, the surgical techniques, shave, discoid, and segmental. If you have any of those questions, we're happy to answer those at the end. The minimally access, early diagnosis, and really raising awareness and feeling empowered to come forward and to raise your concerns and get the diagnosis, and multidisciplinary. And I think that's really, really key. Okay. Thank you very much for your time. You're just on mute, Amr.
Yeah.
Thank you very much, Emma. Thank you. Now, no matter how thorough we are or radical we are in surgery, we know it's a fact of life. Some patients will still have a symptom, still have bowel, and there's where Ganesh comes in. Ganesh, please take it away.
Great, thank you very much. Let me just get this going.
While Ganesh starts his presentation, Ganesh is a functional gastroenterologist. He's an expert in inflammatory bowel disease, Crohn's, ulcerative colitis, and absolutely huge support for us in complex bowel issues. Thank you.
Great. Okay. So my title was looking outside the pelvis, but I'm not necessarily going to do that. So the first thing is that it's got to be endometriosis, right, if there's pain. And this gives you some idea of things that are not endometriosis that can cause chronic pain that can mimic endometriosis. And as you can see, it's pretty complicated. The ones that are starred have sort of grade A evidence for causing severe chronic abdominal pain. And it's really important before saying this is endometriosis that's causing the symptoms that all of these things are teased out, because clearly endometriosis can cause pain, but it's not the only cause of pain, and other things are common too. Often people get labeled as having irritable bowel syndrome, and we'll talk about that in a minute. There are other muscular conditions like pelvic floor tension. There are other things, bladder problems, interstitial cystitis that can cause chronic abdominal pain, and even nervous things. And I can't tell you how many people I see who've had multiple CT scans. They've had, even colonoscopies for abdominal pain and lots of different things. And actually what they've got is a trapped nerve in the abdominal wall because they've been doing too many stomach crunches. And, the treatment for that is totally different to everything else. And so getting the diagnosis right is really, really, really important, because clearly the treatment for all of these things that you can see on the screen in front of you is very, very different. Many people get labelled as having IBS, and IBS is easy, right? You get pain, you get bloating, you get diarrhea, change of bowel habits, constipation, and that all sounds very typical. And if you Google irritable bowel syndrome, you will see countless and myriad posts and websites describing all these symptoms. But the tricky bit comes with this, in that endometriosis also causes pain, bloating, diarrhea, change of bowel habits, constipation, and reduced quality of life. And that's really the thing that, I mean, the last one of those is the thing that obviously affects people the most. Most people can deal with symptoms and they've got their life, but when they're affecting their quality of life, symptoms reach such a degree that it's causing an issue. And that's what, in medicine, we really try to focus on, is that quality of life and saying, what is it that's causing the problem? What can we do to make it better to, restore quality of life? So one of the problems is that there's this issue between association and causation. But what I mean by that is that just because things happen at the same time doesn't mean they're necessarily causative. When people carry umbrellas, the umbrella doesn't make it rain. But if you looked, you could say, well, when there's an umbrella outside, it always rains, so maybe the umbrella's causing it. Endometriosis and IBS are a bit like this. And IBS often coexists with IBS and endometriosis. So we've seen from studies that have been done that about people diagnosed formerly with irritable bowel syndrome by gastroenterologist women, 9% of them have endometriosis, and of women formerly diagnosed with endometriosis, about 14% of IBS. And IBS is really common. It affects up to 25% of the population to some degree and 10% on a quite severe level, and can certainly diminish quality of life as well. And we know that if you have endometriosis, you're about 3 times more likely to have irritable bowel syndrome type symptoms, which can of course be treated. And it's really important before embarking on major surgery of the kinds that we've heard about in great detail just now, that we know that it's not irritable bowel syndrome that's causing the symptoms. You've heard a bit about this, and that cyclical nature of the pain is more characteristic of endometriosis, but when there's symptoms in the middle, like diarrhea and cramping, it can be either. Typically that mucus and nausea are more characteristic of irritable bowel syndrome, but these symptoms are a rough guide and no one symptom is characteristic, so it makes teasing things apart very difficult. What about treatment? Isn't that an easy way to and we'll hear about that in a bit in a minute. This is a little excerpt from the low FODMAP diet, which is a diet that's sometimes used in irritable bowel syndrome, and actually that works in endometriosis too. We can use medications, antispasmodics, things that relax the bowel, and that can sometimes be useful in irritable bowel syndrome. And the other thing that can, of course, be helpful is neuromodulators, drugs that affect the way in which the nerves send signals to our brain. If you imagine we're getting 1 billion inputs every second from our brain, if your computer had 1 billion inputs, it would crash. So there has to be some sort of filtering system to stop our brain from crashing, but like a computer. And so there's that gating process that sends important signals through, but not the rest of the signals. Neuromodulators can help with that gating, which is sometimes disordered. So what's the solution? Because it all sounds very complicated. And as with all complicated things, there's more than one answer here. So we've got to understand that chronic pain is often multifactorial, and many women have more than one condition. So, for example, there could be endometriosis, there could be interstitial cystitis, and there could be pelvic floor dysfunction, all of which mean that the pain is likely more severe than if you have just one condition. And it's really important to identify those because, as I said, if you treat 1/3 of the problem, then you're not going to get a great result. Whereas if you apply 3 different treatment strategies at the same time, then your results are likely to be much better. And it's also important to recognise this centralised pain syndrome that I alluded to, where if there's chronic inputs going into the brain saying there's pain, 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 that causes other signals elsewhere due to chronic low-level inflammation with fatigue, memory difficulties, poor sleep and pain all over. And that is a really important syndrome to recognise, but again, that can be treated in a slightly different kind of way. As opposed to chopping a bit out of the bowel and expecting the fatigue to improve, which is extremely unlikely. So I think the key message here is that evaluation takes time. Many causes of, that you've heard about just now are chronic conditions, and treatment is not always curative in the situation. The important thing is to really define what does success look like. Is it an improvement in symptoms rather than a total, cure? Is more than one treatment strategy simultaneously going to be more useful? And as we've heard already, and I can't emphasize this enough, a team-based approach, because any one of us working alone will not make things better. Thank you for your time.
You are on mute, Emma.
I never take my mute off. Sorry for that. Right. Okay. Thank you very much. Thanks, Ganesh. It's very helpful and very informative. And that moves us very nicely to Elizabeth, actually, because end of the day, whatever we put inside, that's what comes out. And more studies and research now in our scientific meetings in endometriosis telling us it is the gut bacteria which is changing the immune system. And endometriosis partly is an immune problem as well, inflammatory disease, and we see huge rise in inflammatory bowel problem. So I think diet and nutrition is absolutely the key part of what we do. So Elizabeth, please tell us more about it.
Brilliant. Yeah, absolutely. I'm just going to start by trying to share my slides. Let's see if this works. Okay. And then.
Yeah, presentation mode, and we're good. Thank you. Good. Yeah.
Great. Okay. So yes, as you've absolutely touched on already, it's going to be really interesting to hopefully explore the link between our gut and endometriosis, and absolutely what we're taking in does eventually come out. So I hope to be able to explore that with everyone today. So we're going to have a look generally at the overview of dietary strategies in terms of nutrition and endometriosis, and I hope to be able to kind of give everyone an overview in terms of those who are listed for surgery or considering surgery, that what eating and drinking might look like post-operatively. We'll have a look at sort of what this anti-inflammatory dietary approach is and why we recommend it. We'll delve into as well the link between our gut health in terms of supporting our immunity and anti-inflammatory response, and also then highlighting as well in terms of the link between endometriosis and IBS. So if there is anyone who is planned for surgery or considering surgery with endometriosis bowel involvement, what tends to happen post-operatively is that we'll typically build your oral intake up over a number of short days, usually starting off with very simple fluids like juice, squash, milky drinks, and things like that, just so not to kind of overwhelm the bowel so soon after surgery. With the aim of then progressing on to like softer food textures, such as like mashed potato and omelets and soups, with then the aim of eating and drinking a very normal diet and adopting this anti-inflammatory dietary approach to sort of the long-term management of endometriosis from a nutrition perspective. So yeah, this can all be established within a number of short days and will be guided by your surgeon as well. So the anti-inflammatory diet, if anyone has sort of looked up things online and has tried to help gain that sort of insight and understanding on what to do, and they may have come across this term, but it is in essence just the Mediterranean diet. And because the link between foods and diet in particular with endometriosis is fairly limited and quite conflicting in its results, this is kind of our most robust evidence when it comes to supporting our immune and anti-inflammatory response, which is really linked very much so in regards to our reducing our risk of endometriosis lesions developing and spreading, as well as improving overall endometriosis related symptoms. If you're wondering what that then might look like, it is generally just a diet rich in fruits, vegetables, increasing our overall fiber intake, particularly through the means of incorporating beans, pulses, lentils, chickpeas, a focus on low-fat dairy products and vitamin D incorporated into the diet, so particularly supplementing vitamin D in the winter months. And vitamin D is shown to sort of support and regulate our immune system. It's also about the incorporation of healthy fats, and particularly omega-3 fatty acids. So that's your oily fishes like salmon, mackerel, chia seeds, flax seeds, olive oil as well. And then there's this focus on foods rich in antioxidants, so particularly vitamin C and E, which has been researched in relation to endometriosis itself, which is kind of our most suggestive information regarding antioxidants and endometriosis, and that could be kind of sourced from citrus fruits, nuts, and seeds in the diet. And then when we have a look at things that can be sort of limited or reduced in the diet, it's about a focus of reducing our intake of red meat to sort of no more than 2 portions per week, with that overall then reduction of fat and saturated fat in the diet, and a reduction in ultra-processed foods and alcohol as well. Moving on to gut health, it's certainly been very popularly mentioned in the media at the moment, and for really good reason, because we know that the more good bacteria than harmful bacteria in our gut, then the more we're actually supporting our immune and inflammatory response. So our gut health is intertwined with our immunity, and with our GI tract being home to more than 60% of our immune cells and microbes in the body, the two do work together to ensure optimal gut health and immune response. In the interest of time, I kind of want to mostly just draw your attention to, if you were to think of something to take home today to improve your gut health, it would be the consideration of incorporating probiotics. So that can be primarily through the means of live active yogurts, if you were to get it through, via food forms, but also the consideration of probiotic products such as Simprove and other ones on the market. But the incorporation of fermented foods can be a really nice one too to incorporate into the diet. Although they're not labeled specifically a probiotic, they do contain bacteria that are beneficial for health. And those are your things like kefir, kombucha, kimchi, miso, sauerkraut, and so on. Then finally, moving on to endometriosis and IBS, I get the great opportunity here to be able to work with lots of people with IBS and or endometriosis too. And as Dr. Patel's already mentioned, we've already kind of had this research link between the risk of having IBS being 3 times higher in those with endometriosis compared to those without. And actually the prevalence of IBS in women with endometriosis is it's like a nearly quarter of the women experiencing endometriosis. It's quite a high number. And it begs the question of, is this because of the presence of bowel infiltrating endometriosis, or is it that you also have this overlay of IBS with your endometriosis? And it's likely a combination of both, because we know that people can have a real good improvement and resolution in their gut symptoms following surgery, but this may not be the case for everyone, hence why people might still experience that kind of overlay of IBS symptoms despite having had surgery, or besides that in the first place. So there's definitely a role and therapeutic use for exploring dietary means when it comes to managing those types of IBS gut symptoms and endometriosis. So as aforementioned, the low FODMAP diet is a known targeted therapy for IBS, and it's shown a significant improvement in bowel symptoms in those with IBS, but studies are really starting to show some really promising data from Australia and New Zealand that the low FODMAP diets are really positive therapy in combination for those with gut symptoms or IBS and endometriosis. So it's definitely something we're incorporating into our practice. But like plenty of other dietary approaches can be implemented without undertaking the restrictive nature of the diet. And I think that's where the benefit of working with a dietitian one-to-one can be really useful. So much so that if the low FODMAP diet isn't necessarily something you can undertake, studies have shown that incorporating an anti-inflammatory diet or the low FODMAP diet has had an improvement in pain, quality of life, and GI symptoms compared to sort of not implementing any changes at all. So I think it's a really important thing to know that whatever you decide to kind of take home from today's webinar is that there are things that we can do at home from a dietary perspective that may be able to help improve your symptoms and quality of life as a whole. And the key thing to remember from a dietary perspective is that it's about symptom control and improvement, and it's not necessarily a cure for the endometriosis itself. So yeah, that's everything from me from a dietary perspective.
Thank you very much. And that brings us nicely to 1947. So we have 13 minutes left. There's no way we can get through all the questions, but what I will do, Hattie, it is okay if you can start with the questions, Hattie? Happy with that?
Yes, of course. Would you like me to ask you some?
Yeah, you can ask. Yeah, absolutely, far away, and then we can pick up, choose. Then it'll be one line and answers we'll try to do, so we can answer as many as we can do. Please go ahead, Hattie.
Okay. Is there any testing that can be done prior to surgery that can differentiate between scar tissue from prior bowel surgery and further endometriosis?
Ahmed?
Yes, actually the MRI is really the gold standard now, but important is MRI being reported by a specialist endometriosis radiologist, and these are the key.
Thank you. Yep, good.
In what scenarios would a temporary stoma be required?
So, as we said in the talk, it's the commonest question that we get. The temporary stoma would only be if the join or segmental bowel resection was extremely low, or the tissue needed a little bit of extra time to heal. And now the temporary stomas are 3 months rather than the 12 months or longer that used to be quoted. So it's only if it needed a little bit of extra time to heal, less than 1% in current surgical practice.
Thank you. Why limit red meat? Is there any evidence for this?
Elizabeth?
Yeah, that's a good question. It's in regards to the overall effects that has been shown that a diet high in red meat and processed meats, particularly kind of exceeding that public health guidance of more than 2 portions a week, actually has more of an inflammatory effect than it has an anti-inflammatory effect. And that's quite widely researched and evidenced in many chronic diseases and cancers that we see today, such as colorectal cancer. So that's definitely one thing that even as a public health guidance, we should probably all be implementing as best we can.
Thank you. What is the percentage risk of this type of bowel endometriosis turning into cancer, or in general, the risk of endometriosis developing into cancer?
So we have seen now, we're talking about bowel endometriosis. So at my knowledge, none, and Emma will tell me more. But if it's the ovarian endometriosis, the recent study from Surrey tells us that ovarian endometrioma has slightly high risk of turning into cancer as compared to if there is no ovarian cyst. So but on the bowel side, no, there's no evidence. But Emma, anything you want to add? Yeah, no. Yep.
Absolutely. Bowel endometriosis is not a precursor for bowel cancer. Absolutely. There's no evidence at all.
Are there any good gut probiotics to take if you are vegan?
Ganesh?
Yeah, Simprove is pretty good. You can try that. That's vegan. SYMPROVE.
Thank you. A more specific question. I'm having a bowel resection in a month. 2 years ago, I also had a rectal shaving to remove my endometriosis. What are the chances of me needing a stoma in the future if I have regrowth in the bowel again?
Right. So you had a bowel shave done first, and now you're going for bowel resection anastomosis. I'm assuming that shave was incomplete. And on a further MRI scan, imaging, and assessment, they found that the lesion is much deeper, hence they're going for bowel resection anastomosis. Given that previous surgery has been done in the pelvis does increase the risk of stoma because the previous surgery has been done very recently. But again, as Ahmed said very correctly, that there are many reasons why we will do stoma and we'll avoid stoma. If the anastomosis is very low, if there's a huge inflammation around that area and the tissue is friable, then possibly they will do stoma. But given that it will be a temporary stoma for 3 months, it can be reversed successfully. So you'll be guided by your clinicians and have a discussion with them in detail.
Thank you. And a question, why perform endometriosis surgery if it's not a cure and there's not a guarantee a person might get better?
I mean, other people can chip in as well. From my perspective, it is first of all, endometriosis is an anatomical defect because of scarring. But the problem is it turns into functional issues. Endometriosis can lead to renal failure, kidney will be damaged. Endometriosis can lead to severe bowel problem, obstruction problem as well. So it's not only the anatomical defect we are trying to fix it's the functional defect and problem which have absolutely long-term problems with these patients. So surgery is needed in these cases. Obviously, we'll explore all the medical options as well in any such case.
Thank you. Does taking the pill, Sorel, I believe it's pronounced, stop the progression of endometriosis?
I won't go into one pill or the other pill, but the basic fundamental principle is that endometriosis is estrogen-dependent disease. Any hormone which can block the estrogen can help your endometriosis, and we can go ahead from Dynagest to Ryco you heard in the market nowadays, any combined contraceptive pill, but ideally progesterone-only pills are much more effective, so you can take anything out of that lot.
Are there any studies that show if endometriosis is hereditary? Both of my sisters have it very badly.
Can be, yes. It's a poorly understood disease. There are a lot of factors, immunological, other factors as well, and hereditary is one of them, yes.
What's the prognosis for someone with adhesions between the cervix and rectum? Is further bowel endometriosis likely?
Ahmed?
If it's adhesions alone, then not necessarily. No, it's the treatment of the primary endometriosis disease, but adhesions alone doesn't make it more likely.
Do kissing ovaries only present in endometriosis?
A kissing ovary is a term we use for endometriosis. Endometriosis is an adhesive disease of scars. So these ovaries, which should be lying right and left of the uterus, are pulled inside, stuck on the back of the uterus. Hence, we call them kissing ovaries. Very typical word used for endometriosis. Yes.
Thank you. What training in endometriosis awareness are general colorectal surgeons receiving? I had 24 centimeters of my bowel removed because they thought it was a cancerous lesion, but it was in fact endometriosis. I don't want others to go through this.
Multidisciplinary team, myself, Ganesh, Ahmed, everybody repeated the same thing. It has to be multidisciplinary care, preoperatively, and not only preoperatively, even during surgery. It has to be a dynamic discussion and challenging each other to get the best out of that surgery. And that's, I think, what should happen. And that's the way to do it. Ahmed?
Oh, yeah, I will add to that. What we would really say is go to an endometriosis specialist center. The days of people doing a little bit of everything, those are gone. Colorectal surgeons should be detailed and experienced in dealing with endometriosis, as well as the radiologists, the gastroenterologist, the dietitian, and the gynecologist. Everyone doing a bit of something. Now, these are specialist centers now.
Thank you. How can someone effectively differentiate between the symptoms of bowel endometriosis versus a disorder like IBD, IBS?
Ganesh, I think, can come in.
So inflammatory bowel disease is quite easy to tell with stool testing. With irritable bowel syndrome and endometriosis, as I said, there is an overlap there. So it's what kinds of symptoms, how they're affecting people, whether certain symptoms predominate over others, and sometimes even just a trial of treatment of irritable bowel to see does that make things better. That's not an unreasonable thing to do, and see within a couple of months if things are better. If they are, then sometimes that helps point towards a diagnosis as well.
Thank you. Endometriosis was only seen in/on my bowel on an MRI. Does that mean it's likely to be elsewhere?
If endometriosis is seen on the bowel, then the most likely scenario is that you will have the whole pelvis involved with endometriosis. Right pelvic side wall, left pelvic side wall, back of the uterus, back of the vagina, likely uterus. So answer, I'm afraid, is yes. Bowel endometriosis means disease has now spread outside the uterus involving multiple structures.
Thank you. What is your advice on best practice for diet if you're autistic and struggle with diet generally?
Yes.
I would say in that context, it's a very individual and tailored approach. And I think an overall broad recommendation may not be necessarily the most appropriate thing for that person. So I think there's huge benefit that can be explored with working with a dietitian one-on-one, particularly if you find that the overall generic advice isn't necessarily tailored to you and your needs. So I would recommend seeing a dietitian, either one of us at the Cromwell Hospital, and we take self-referrals, as well as referrals from referring consultants for dietetic input if you require, and particularly in the case of endometriosis as well. So,
thank you. What care is available for under 16s?
So we are fortunate to have Dr. Maya Mimar in Cromwell Hospital. Every large hospital should have adolescent gynecology. So if you are under 16, please check with your local hospital. There should be a department with adolescent gynecology where they take care of anybody from 12 to 17 and 18. In Cromwell Hospital, we have Ms. Maya Al-Mimar, and we take off all of them who are younger than 17-year-old.
Thank you. If progression is halted or reduced by the pill, is it still possible to noticeably minimize or eradicate pain and bowel issues without surgery?
We know from our medical data that when we give hormonal suppression with any of the pills we just briefly talked about, in 70% of the cases, it can reduce the symptoms of pain and other relevant symptoms as well. But in 30% of the cases, endometriosis still continues to grow even if there is no symptom. So I'm afraid you have to have a continuous follow-ups and workups even if you're taking the medical treatment.
Thank you. Staples and sutures being used was mentioned in a presentation earlier. This person would like to ask, how is this adapted for someone with a nickel allergy and a connective tissue disorder like Ehlers-Danlos syndrome? Apologies for the pronunciation.
Emma?
So the sutures that we use, they're titanium rather than nickel, and they don't have a nickel content. And if patients have individual allergy to certain equipment, we would use sutures that would be in line. We have sutures that are dissolvable as well, so non-permanent.
Thank you. I think we're covering most of the questions quite efficiently, and we have had a new one. Can bowel endometriosis still affect your fertility?
The fertility, obviously, if we look at the environment outside the uterus, we have a fallopian tube, we have ovaries which are ovulating, producing eggs, and then fertilization is happening where? Not in the uterus. Fertilization is happening outside the uterus, near the fallopian tube and ovary. And if that environment is full of immunological inflammation around it, then obviously that fertilization will not happen. The tubes can be blocked. There could be a number of factors. So I'm afraid when there's a bowel endometriosis or severe endometriosis, it does impact fertility. And all the data confirms it. Maybe I can ask a question here now from Anna, actually. Anna, if that's okay, if we can quickly ask a question, and we're getting to the end as well. Anna, what is the best advice you can give to patients who are suffering with bowel symptoms and now in problem now? What your advice would be?
So I was just going to say, in regards to fertility, just to give like a small amount of hope to somebody, because I had my daughter naturally after trying for 2 years, after my first bowel resection. I was even though it was difficult, I was closely monitored by a obstetrician who specialised with kind of on the bowel side. So even though it can be frightening, it's something that can happen, and it's not that it's off the cards for you just because you've got bowel endometriosis. So I just want to give a slight bit of hope there to somebody, because I know how difficult it can be, because I suffered with secondary infertility. From regards to bowel endometriosis, listening to everybody tonight is incredible, in a sense of it's a really multidisciplinary approach, and that's something that I definitely didn't have in my care. I was past pillar to post to people, colorectals, who didn't ever deal with endometriosis. So I think that was why it was overlooked for so many years, in a sense of trying to monitor it post resection, and why it kind of went from 0 to 100 very quickly. So I think stick to your guns if you really are struggling. Please, I can't stress it enough to do a symptom diary. And I mean everything from kind of your food intake to your pain, kind of your pain tolerance day to day, to what medication you're taking. It really does help people be able to kind of give them a better overall picture. And I think talking earlier with IBS versus endometriosis, it also can really differentiate what's going on. And do your research. So what kind of webinars like this of what you're entitled to. So like for me, I had no idea back then about BSG centres, and I know sometimes it's about accessibility. So like I'm based here in North Wales, we don't have a BSG centre. We also don't have a right to choose here in North Wales, so it makes it really incredibly difficult. But you are entitled to that care, and there is a way around it. It's just by going down the different avenues. At Menstrual Health Project, we're more than happy if anybody's got questions on kind of individual kind of pathways, especially here in Wales, because I've navigated it myself. Across the UK, we're more than happy to help and kind of advise on what we're able to kind of give pointers on how to navigate and what you're entitled to. We also do have symptom trackers on our toolkits that are helpful, and an IBS versus endometriosis resource. But my biggest thing would be track everything, that nothing is too much kind of detail, and don't suffer in silence. And if something isn't right and it's happening continually after a few months, then that's not normal, and to find help and find people like yourselves to kind of really listen to you. And I do really want to kind of point out that we know accessibility isn't easy across the UK with different centres. So where we can, we will advise the best how we can best advise on that and get you to the right place, because I think it is currently a bit of a minefield when it comes to ensuring that you get a good MDT team when it comes to kind of outside of the pelvis endometriosis, as we know it's happening with kind of bladder and thoracic and things like that. So it's just knowing where to go, and webinars like this really help.
Thank you very much, Anna. Thank you. Hattie.
Thank you. Yes, we've had quite a few questions, so let me just scroll up to see. Is there a link between endometriosis and UTIs? I've had multiple
Carry on.
Sorry, there was a bit of a longer question there. I've had multiple UTIs and ended up in A&E with terrible abdominal pain further up. They noted it as renal colic, which they put down to the UTI, and also say it may be coming from my endometriosis, deep infiltrating endo in the uterus, in both ovaries, invading the bowel on the left and the pelvic ligaments on the right. And then just ask if that could be, if the endo could be causing it.
I think it won't be fair to give a comment without knowing the whole history, so I will be reluctant to do that. But general answer is yes, endometriosis can cause severe bladder symptoms, which may look like UTI, but actually it's endometriosis. So I will suggest a proper investigation should be carried out.
Thank you. So I'm just if I had a normal colonoscopy but continued symptoms, e.g. rectal bleeding, severe constipation, and endometriosis found during a laparoscopy unexpectedly, could bowel endometriosis still be possible?
Ahmed?
Yes, absolutely. I think, again, case by case, but with an MRI, that would be a very good indicator. And having a review of either the video or the images of the laparoscopy will tell us as well. But yes, it can.
I think I'll just add here, I've seen quite a few questions on those lines as well. So endometriosis in cases, bowel endometriosis grows from outside inward toward the bowel. So it involves the serosa outside, then muscularis, then the inside mucosal layer. So if you're doing a colonoscopy from inside, when you see from inside mucosal, actually they may not see anything at all. Even a thick, deep lesion muscularis involvement, mucosa will be normal. So normal colonoscopy or sigmoidoscopy doesn't rule out endometriosis. It's a false perception. Actually, we have stopped doing them pre-operative colonoscopies now in Cromwell Hospital. We do them intraoperatively, and MRI scan, as Emma said, absolutely the right way to diagnose the depth and the severity of bowel endometriosis.
Thank you. A lot of the questions we've started answering in the chat, but a new one has just come through. Does an MRI only show deep-seated endometriosis?
So a big study was done which showed when we did the MRI scan for mild to moderate endometriosis, the trial was halted after about 18 months because we found that it was not very good predictable in mild to moderate peritoneal endometriosis. But when there's a severe endometriosis involving bowel, kidneys, ureters, all those things, yes, MRI scan is a very good predictor, but as Emma said before as well, it should be seen and done with the endometriosis protocol and reported by an endometriosis radiology consultant. Otherwise, they will look at it and they won't find anything.
Thank you. Maybe a couple of questions looking at the time to finish up, but what can I do if an endometriosis specialist refuses to see me due to age?
How old is she?
Unfortunately, this person has not put their age on.
They should consult their doctors. I'm sure GP and doctors can help her.
Oh, 15. 15.
They should go to adolescent gynecology. Not every gynecologist will be able to see 15-year-old. They will see a pediatrician or pediatrician interest in gynecology or an adolescent gynecologist. If she does not have it in a local hospital, just Google it and possibly go further afield and find some expert. I'm sure she will find one.
This may have already been answered. Can IBS medication such as Buscopan be beneficial, or could that cause further bowel issues?
Ganesh?
I mean, Buscon has virtually no important side effects at all, so it's worth a go, and it can help spasm if you're getting spasms.
Okay. I think this might be wait, we just had another question in. Some of the final questions now. What kind of MRI would show bowel endometriosis? Is it a pelvis MRI or a different type?
Ahmed?
This would be a pelvic MRI with endometriosis protocol. Again, would echo the purpose. It should be done by a radiologist that deals with gynecology endometriosis specialist.
And then I might I'll just ask this one last question, I think. This person's currently under the care of multiple different specialties: cardiology, colorectal, gynecology, urology, and endometriosis was found during an emergency surgery for ovarian torsion. Do they have the right to ask this question, I'm assuming, of all of their specialists, whether it might be endometriosis, because their care is not currently joined up at the moment?
I mean, I didn't get the question fully, really. I mean, if they found endometriosis, an opportunistic finding of endometriosis during a dermoid surgery, and the surgeon has not consented, and then they will possibly do a repeat surgery afterwards to treat the endometriosis. But again, it needs a discussion what symptoms she has or she hasn't, and then they will make the right decision after consulting and talking to her.
Thank you. Would you like one further question?
Okay, one last, that's it.
One last question. Thank you so much, everyone. Someone has asked if there's anything to help the dragging feeling.
So I'm going to bring in a wonderful panel of physiotherapists, musculoskeletal team, chronic pain team with me, hopefully in 1 month's time or 2 months' time, to talk about this in much more detail. So watch out for the next webinar.
Thank you so much, everybody, for answering the questions. I think we managed to answer most of them.
Thank you very much. And actually, whatever the question left, our specialist nurse, Denaya, she's a very active in Cromwell Hospital. She'll pick up these questions and we'll try to answer these questions on this webinar as well. And I think I would just say in the end, thank you very much for all of you who have joined us. And I can see the number of people who joined us. They're all still here after this hour and no one has gone. So thank you very much. And thank you for wonderful panelists who came in as well. Ganesh, Elizabeth, Anna, especially you, Ahmed. And thank you, Hattie, for arranging this wonderful webinar. Very kind of you. And thank you, everybody, and good night.
Thank you.
Thank you very much. Are we closed, Hattie?
Just leaving the slide up for a moment.